Hi, and welcome to another episode of Every Possible Angle. I'm here joined by my co-host, Pratik Patel, the Director of Product Management at Paragonix. And we're very excited here to welcome today Dr. Ahmet Kilic. He is the Director of Heart Transplant and Mechanical Circulatory Support at Johns Hopkins Hospital. Thank you so much for joining us today.
Thank you so much for having me.
Really excited for this conversation. Recently, your team has had an incredible accomplishment of 5 heart transplants in 7 days, which is an incredible growth and monumental challenge to be able to serve your patients in that way. But before we dive into that, I'd love to learn a little bit more about you, about how you got into heart transplantation and how your journey has gotten to this point.
Yeah, absolutely. I was born in Turkey, and my family immigrated to the U.S. when I was 9, mostly for an interest in education and opportunities. I kind of found myself stumbling into medicine because my mom said you should be a doctor. Probably not uncommon for a lot of people out there. And once I was in medical school, I absolutely loved the heart. I loved the cardiac physiology, the way you could stop the heart and get it beating again. And as my introduction became more of a maturation of ideas, I found myself gravitating towards the sickest of the sick patients. And that usually meant those whose hearts weren't functioning appropriately and needed machines or transplantation. And I mean, let's admit it, when you see a heart transplant, there really is nothing that captures the imagination of replacing someone's organs and watching it beat in real time. So I've been fascinated with it. It's absolutely amazing what we do. And I'm in love with transplantation.
Just the most incredible part of the process and the change in patients from before transplantation to after. It's just remarkable.
Yeah, it really is amazing. You'll see patients who just their entire organs are shutting down because of the lack of cardiac output. And next thing you know, you temporize them with some medications or some machines. They do a little bit better. You get the organs a little bit better. And then all of a sudden you put a new heart in them and they're kind of on their way. It's like a second beginning. It's like a second life. It's just, like I said, it captures the imagination of figuring out how to get patients to this therapy successfully and give them a second lease on life. And I've had the pleasure of doing that for a little bit over a decade now, and it's absolutely amazing each and every time we get a chance to do this.
I think to that, this recent accomplishment where your team did 5 transplants, heart transplants in 7 days, that has to be an incredible strain and burden. Obviously, there's incredible orchestra and a lot of large team members involved with this. Tell me a little bit about how this came about. How did you approach this, and what that meant for those patients that were involved?
Absolutely. It takes orchestrating a lot of different people in terms of the team members, in addition to ensuring that all of the sick patients get appropriate treatment. And it really all starts with identification of appropriate patients, which my heart failure colleagues really do a wonderful job of. They see patients in the hospital, out of the hospital, and sometimes referred from a different facility that really need help, either machines or transplantation. And their ability to identify these patients in the right time so that they can undergo a major operation like a transplantation is the key. Obviously, they're supported by a whole cadre of other specialists. We can't do any of this without our coordinators and social workers and financial advisors and nutritionists and just a physical therapist, just about anything and everything you can think of. From the surgical side of things, I have the luxury of having 2 absolutely wonderful partners, Dr. Antonio Polanco and Dr. Chain Pasricha. And we work seamlessly. We probably talk more times than we should have on any given day to coordinate who's where and how we can take care of these patients. So the unpredictability of transplantation becomes something that you can kind of manage, what I like to call a little bit of joy in chaos, so to speak. And this example of 5 transplantations in 7 days is absolutely the epitome of that.
And I'm just curious, before these 5 cases in 7 days, did you ever have as a program so many cases in 7 days or even close to 5 cases? I'm just curious how this came about. I'm sure when you had the first one, you didn't know there were going to be 4 that were going to be following pretty quickly.
Absolutely. So this is a blimp. Usually, we're not as busy as this. At the same time, there has been a huge upsurge because of the dedication of the team and a focus at Hopkins in heart transplantation. And a lot of it has been done by laying the groundwork and the foundation for the past almost 6 years, to be honest. And with the increased focused on the fact that we're trying to get these sick patients across Maryland and many of the states that are bordering us into this end stage heart failure therapy, we've been able to organize and orchestrate things a little bit more smoothly. And what I mean by that is that we identify patients that are maybe on the sicker list that were outpatients and bring them in before they get into trouble with their end organs. We identify patients that are in our sister hospitals that are having trouble not coming off of inotropes, have evidence of heart failure, and we bring them into our center as quickly as possible. In addition to that, patients that are actually in our hospital at Bayview, which is just down the street from us, those patients that are in big trouble, we get them in here, put them on MCS as quickly as possible. And once we put them on MCS, we stabilize things and we work them up towards transplantation. So even though I say it's a blip and there's 5 transplants in 7 days, we've done about 17 transplants in just over 2 months. And so the program is really firing on all cylinders right now. And it's because of a focused attention to ensuring that we get these patients safely through their sickness.
It sounds like there must have been a lot of effort, like you're saying, over the last 6 years. This isn't a random chance that you're able to do this, but required a lot of both organizational buy-in to have the right people, have the right systems, but also relationships out to the community, to community physicians, other partner hospitals, to make this possible. To grow a program like that over the last 6 years and put those pieces in place to be able to change a program to be able to, like you said, even 17 in the last 2 months it's a huge growth for Hopkins. How do you can you say a little bit about how that's come about?
Absolutely. I think the first thing you need to do is lay some foundational work. And what I mean by foundational work is establishing protocols, ensuring that everything that you can think of that can go wrong, you have a plan for, and that the right personnel are in place. And that's what's happened, I'd say, in the last 3 to 4 years. In academic medicine, things change. Things change constantly. And for us, the makeup of the team has changed quite a bit in terms of both the surgical side as well as the heart failure side. Dr. Kavita Sharma assumed the leadership of the heart failure group about 3 years ago and has done an excellent job putting together a wonderful group of heart failure cardiologists as well as systems with regards to coordinators and listing criteria and the like in terms of the protocols to get these patients through. The next thing after that becomes the absolute quality. And what I mean by quality is getting patients that are sick, doing transplants, having excellent outcomes with regards to both 90-day mortality, 1-year survival, and absence of complications, rejections, infections, graft failure, and those things. And over the last 2 years, we've done a wonderful job with that. We have a survival that exceeds 94% while we continue to build the volume. And once we have this foundational groundwork done and you have the kinks worked out in the system, you can really start revving the engine, so to speak. Mm-hmm. And that's what's happening now with the addition of 2 other heart failure surgeons, your partnership with you guys in terms of the way we can get these organs that are sick and have more trust that they're going to work great by expanding both the traditional criteria that we would have used for heart transplantations as well as the distance that we would be willing to go. And with all of those things in combination, it really leads to a huge growth in the program that we're seeing.
Yeah, the last few years, we've seen big changes to policy in terms of opening up longer distances, but also changing in waitlist status and MCS technologies and temporary support. Also, preservation approaches and our understanding there. Can you tell me a little bit more about adjusting to those and what kinds of patients are you considering, donors are you considering now, in terms of that you wouldn't before in terms of either distance or marginal criteria?
So certainly the heart allocation change that happened late in 2018, it changed the game for everybody, not just Hopkins or the Mid-Atlantic. Patients now, we increasingly started bridging with temporary devices, balloon pumps, impelled devices, and ECMO. To be honest, before this, ECMO was seen as something that we never wanted to do because the outcomes following transplantation off of ECMO were dismal. Now, this isn't the first time that this has happened because the European system, particularly the French experience, went through something similar and showed that you could have excellent outcomes with patients bridged to ECMO. And that's what I think has really spread across the US right now, is that we've seen a huge uptick in temporary devices that are used to get patients that are otherwise moribund to get them successfully to transplantation. Now, with that comes the fact that we have a cohort of recipients that are technically sicker, more challenging, higher lengths of stay, and perhaps a little bit of increase in organ dysfunction. So while we're taking somewhat educated, calculated risks on the recipient side, we're also really pushing the boundaries on the donor side. When you are in a place like Hopkins that sits dab in the middle of the Mid-Atlantic in Baltimore, Maryland, and you're competing with other centers that are about 1,000-mile radius, you're pretty much competing with everybody on the East Coast. And you have to be thoughtful about what type of donors you can take and how you can best strategize to make those donors successful. And for us, it's been really partnering with a couple things. We've partnered with a procurement team so that we can have immediate availability of all of these organs across any region. Partnering with you guys with regards to preservation solutions, where we can make sure that the hearts can be ischemic longer without having thermal damage when they get restarted at the recipient site. And with those two strategies, we've been able to expand what I would call the standard criteria. Standard criteria being, ideally less than 4 hours of ischemic time, but 6 hours, maybe not having a donor that's a little bit younger. It's interesting that the European donor age had increased over time, but the American experience had been in the 20s and most recently in the low 30s, which is really a shame because as I get older, that age seems younger and younger to me.
I know the feeling.
I think those are some of the things that we've certainly changed that has led to an improvement in access to patients that really need transplantation as a sole way of getting past their sickness.
Yeah, Dr. Kilic, one thing I'm interested in understanding, and maybe for our listeners as well, is, you talked about such a big team of folks that are really involved in getting patients transplanted. When an offer does come in to your institution, what is that process? Like, who all are involved? And I imagine this happens at 2 p.m. or 2 a.m. So I'm curious to understand like what that process is, who all is involved, and maybe a little bit of like the timing of things as well, because I know that can vary quite a bit.
Absolutely. So to try to make things as streamlined as possible, one of the surgeons is always on call with one of the heart failure cardiologists. So that way, that's the fail-safe mechanism to be able to get immediately feedback as to whether or not we're going to accept an organ. Mm-hmm. Usually, it's a group decision. But we text at 2 a.m., 1 a.m., whatever the time the organ comes, and usually everyone's very quick to respond. And that we found maximizes the way we think about things. So in most centers and organizations, the more people you have, the more stagnant things become. Mm-hmm. We've kind of taken the different approach of the more people that look at it, the more we are trying to figure out how we can make it work.
I see.
And that has really led to us being a little bit more aggressive in terms of the donors that we take. We work with and partner with OPOs and essentially try to get these organs, if they're not perfect, to do a couple of different maneuvers, like the right atrial pressures are high, give them some Lasix. If the first echo wasn't that great, but they need a little bit more time from the stenting, give them a little bit more time. And we found that by working with the local OPOs that we've been able to really increase the number of organs that we are accepting.
And what range are you going out to? You said historically you considered 4 hours. That probably means if you're going out to 6 hours, that probably means more OPOs and more groups across the country that you're coordinating with.
Yes, we're trying to reach out to as many centers as possible. It's not unusual for us to be on the UNet, which is our way of looking at organs, and partnering with the OPOs. Like I said, it does or give us a lot of flexibility to partner with so many different people. And as a result, communication is really key. Well, we have made our distance criteria up to 1,000 miles, which often means that the transport time itself takes close to 4 hours.
Wow.
And that doesn't account to all of the other variabilities that kind of exist in the system. So we've become increasingly more comfortable with that. And we really haven't found a huge difference in terms of the way the organs are functioning right off the bat. And we think that a significant reason for that is the way we look at organs and we evaluate them, and also because of the preservation techniques of keeping euthermic and knowing exactly what that is.
Going off of that, to understand that a little bit more, there's a bunch of clinical considerations, like you mentioned, donor characteristics, specifics to the organ as well. When does the considerations of logistics come into play? For instance, how are we going to get the organ, how far it is, what type of preservation methodology? Is that a consideration from the get-go, or is that a consideration after a point that you've considered all the clinical parameters?
Yeah, no, absolutely. We take that into account immediately when we hear of an offer. Obviously, if it's something that's going to be really a time-sensitive thing where we can't get our team organized in time, we won't be able to do it. At the same time, because of the fact that we've partnered with so many different groups here, we haven't ever run into trouble.
Got it.
And that's what I think makes it really great for us, whether it's calling patients in with our coordinators, getting the operating room ready, or having a procuring surgeon on the phone call, or having the ability to use the Sherpa pack. All of that stuff has enabled us to have great flexibility. So out of those 5 organs that we talked about, some of them were last minute. It was an immediate, can you get here within 6 hours and this is what it is? And the answer is the same. Absolutely. Because we have the ability to do that with the partnerships that we form.
And when those 5 cases were going on, obviously they happened over 7 days. Maybe some of them were going on at the same time, perhaps in terms of procurement or the transplant procedure. How did your team stay coordinated? Because I assume, perhaps the team was, some team members might have been out on the procurement, other team members might have been in the OR. How did you guys stay coordinated? You mentioned texting, for example, during the evaluation stage before the organ is accepted. But what about during the actual procurement surgery? I'm curious how the team stays coordinated at that time.
Yeah, absolutely. So that's the nice thing about having a team. I can't underemphasize that. So we had 2 surgeries simultaneously. One as it's kind of finishing up, and the other as it's starting. From a pure procurement side of things, we have a partnership with one of the procurement companies. So that takes that out of the equation for us, because that is very unpredictable. And sometimes you get stuck at procurement facilities, and rightfully so, because we're trying to do the best for as many organs as possible. And any altruistic donor can save up to 8 different patients. And so we don't ever want to undercut that process. So the fact that we're able to partner with our partnership teams is really a benefit for us. In terms of the surgeons, we tried to get a little bit of a life-work balance, but that doesn't ever work. So we try to make it a life-work integration. So between the 3 surgeons, we try to get 1 week when you're on, 1 week when you're back up, and 1 week when you're kind of doing your academics and things like this that we're able to do with you guys today.
Right.
And we communicate. If it's, hey, there's too much clinical volume, I really need help with X, it happens in real time. And like I said, my 2 partners, Dr. Antonio Polak and Dr. Chain Pasrija, are absolutely workaholics. And it's the kind of the complete opposite, where you say, okay, I got this one, you guys can relax, as opposed to saying, can you help me? And so that's the kind of attitude that we take. So for us, it was very easy. It's essentially, if you think about 5 transplants, it's maybe 2 transplants per surgeon. So it's not as clinically crazy as it sounds. It wouldn't be for 1 surgeon. At the same time, it's not just about the surgeons, it's all about the process too. So having our cardiology colleagues that are flexible and adaptable enough to bring patients in, talk to them, counsel them, make sure that they're okay with perhaps increased risk donors, making sure our coordinators have everything, all the T's crossed and the I's dotted, was very important. In addition to the capabilities of the operating room staff to be able to work things that are more flexible, because none of these organs that became available 9 to 5. It's most of the time after hours in the late night or at early mornings. And the team at Hopkins has absolutely been wonderful about that. After all of that is the ICU care. We are, fortunate enough to have intensivists that are in-house I would actually have 2 intensivists in-house for our intensive care unit, which can flex up, flex down, whatever the cases are needed. And they did a wonderful job of accommodating, working with us to ensure that there was a smooth output and smooth post-operative and perioperative care for these patients.
And I'm curious, after going through a period like this, which obviously was a new sort of high watermark in terms of number of transplants in this short period, do you feel like that's helped build, or sometimes those periods of high intensity help build organizational strength to be able to continue to grow and see where you're strong and where you need to continue to build up resources and strength? How has that sort of helped you on your journey of growing this program?
Absolutely. And anytime something like this happens, everyone gets excited, right? It's a big feel good, especially because the patients all did well.
Right.
When patients are doing well and you're doing a high volume, it's kind of times of stress, and the whole team kind of came together very nicely. And there was no complaining of, oh my goodness, it was, hey, we're doing another transplant. This is exciting. And when that happens, it kind of strengthens the bond of the team, because everybody knows that we all play a role in things to get us to this kind of high volume, high quality. And so it really, I felt as though it's really made the team stronger of seeing, hey, look at what we accomplished. That was a tough week. Yeah. I hope we don't have that again next week.
No, but I think what you're saying there, I think it's so true, and it drives a lot of our team too. Is being in such a mission-driven space. It's demanding. It's highly volatile. All of healthcare is very mission-driven, but I feel particularly in transplantation, when there's such high demands on people and such intense periods of work. Also taking the time with the teams to recognize these big wins and the mission behind it is so critical, because I think that's what helps people and teams continue to drive harder and grow. We see it in our own organization every day.
Absolutely. And I think that's in just about every organization that requires, more than one person. And I don't know whether it's, and there's so many cliches about sports or military groups or high performing organizations, but it really is true. The people that you are kind of, elbow to elbow with during times of stress are the people that you make the biggest bond with once you're past that. And that's what we found, is that the team has just been really absolutely enthusiastic about this. Every single person we talk to, I'll be walking by and there'll be somebody who's, maybe the physical therapist, and say, that's great. Then we do this the last week. And you're like, wow, that's kind of cool. This positive energy, this positive vibe kind of has a ripple effect on the whole institution. And that's what we found. So probably similar to your experience. And it's been absolutely a delight to be a part of.
And it also reminds me, I think, for us, and this is kind of taking it into a different area, but this idea of pushing boundaries and continue to push up and find new fronts. In terms of what we do on the academic research side of things, we're running these real world registries, and I think because it's such a dynamic space, we're trying to keep track and be able to really understand, as people are pushing the boundaries on ischemic times and donors and the combination thereof. Understanding, if you have an older donor that you wouldn't have considered before and a longer ischemic time, how does that affect the donor heart? Does it work in certain recipient conditions? I think real world evidence, as we're all learning together and growing sort of the transplant field, trying to increase the number of viable hearts and the number of recipients that can be treated. To me, that's one of the driving forces for our research group of what we're trying to do and move the field forward. And I have to say, I truly appreciate collaborations with groups like yourselves, because it helps us understand where your questions are and what your scientific questions are, and can we push here or there. And I guess to that, where do you feel are some of the next frontiers for the transplantation field and for heart transplantation?
Yeah, no, that's great insight, and that's exactly what we struggle with is the crux of the question, which is that there's more people who need transplants than organs that are available. So how can we maximize the amount of organs that are offered? Historically, heart transplantation has had a lower utilization than other organs.
Mm-hmm.
And so the question is, are we not utilizing as many as we should? And so I think that's the central question, whether it relates to ischemic time, age, potential quality, stunning of the heart. It's all kind of the same thing. The problem is that heart transplantation is probably the most scrutinized specialty there is in medicine.
Mm-hmm.
And because it is such a scarce resource that we want to make sure that we are having good quality with the hearts that have been chosen and transplanted through the complexities of the system that we just talked about. So for me, I think we're going to continue to push the boundaries by having registries, by having these kind of discussions that we're talking about, case series. And I think the biggest opportunity is going to be in our ability to potentially repair or regroup or refurbish, so to speak, organs that would have been traditionally turned down. And for me, that's going to be utilization of some kind of MCS support,
Mm-hmm.
whether it's ex vivo stuff, NRP, to see what the heart function is, and perhaps take some therapeutic interventions. And those are, I think, the biggest areas of research that will be basic science foundational to really change how we think about organs.
And in specific to your organization, your heart transplant program's goal, you mentioned about 17, or you've done 17 to date in over 2 months. So that's about at a rate of almost 100 for this year, which is absolutely incredible. And I just want to understand, when you think about that growth, where does where's the focus for the program? Is it to get more patients, like you mentioned, through the heart failure partnership that you have, of getting more patients from the community into the Hopkins Heart Transplant Program? Is it from accessing more donors, or maybe a combination of both? I'm curious to see where, how you look to grow that program this year.
Yeah, from an organizational standpoint, it's getting access to patients that really need help. Some of that is within our borders of our health system. Some of them are just outside of our health system. And for those patients that are suffering from heart failure across Maryland, we want to partner with groups that aren't necessarily affiliated with Hopkins, but we share the same bond of taking care of patients that are really sick. And so our heart failure group has done a wonderful job doing outreach and reaching to the community to ensure that they know that there's a place where these patients can get care. Same thing goes for patients that are actually in the Hopkins system, to know that patients that are maybe sick and suffering and their heart's not doing well and they have perhaps an arrhythmogenic issue or a valvular problem, that they know that we have options and support for them that may be outside of the realm of their specialty or the way they look at a problem. And so we've done a lot of work in both outreach and intra-reach to ensure that people know about the transplant program and the advanced heart failure program. With regards to recipients, we talked about the foundational laying a solid foundation with excellent outcomes. And what that does is it allows us to kind of push the boundaries with regards to recipients. And what I mean by that is perhaps a little bit of an older recipient that we would not have traditionally thought about. Perhaps a recipient that has a little bit more renal dysfunction or liver dysfunction, or needs multi-organ transplantation, or has PRAs and needs desensitization, or has complex congenital abnormalities. Those are all the patients that we are starting to look at, that whereas before we were really concerned about ensuring the foundation being laid okay. Now we're concerned about making sure that each individual patient gets the help that they need. And as a result of this, we're seeing, wow, with a different lens, there are so many people who have really bad heart failure who really could benefit. And I think that realization is what has kind of spurred this growth.
I think that's so true. And I think it just points out, again, there's the whole field right now, I feel, is shifting very quickly. There's new frontiers considering on risk on the recipient side, considering risk on the donor side, new technologies and the policies that allow them to take place. How do you evaluate those conditions and when you move those barriers forward? I think to your point earlier, you said there's a group of donors you used to consider more challenging. Now you consider standard criteria. I think that's an exciting concept, that there's always going to be a cutting edge frontier, but hopefully what we're doing is we're learning and getting smarter, that those things that are sort of on the cutting edge right now become standard criteria tomorrow, and help us just grow our understanding, grow our pool. But how do you approach those questions as you're facing those in the real time in the clinic?
Yeah, well, that's a tough one because it is ever so changing. And I think what you need to appreciate that is that no one has the right answers for everything.
Yep.
And that by having a team of individuals looking at things in different lenses, you kind of get an idea and a picture kind of forms. And for us, that's by regularly and routinely looking at quality. Every week, we have all of the donors that were offered to us, and see what our utilization rate was, what our acceptance rate was. And those that were maybe transplanted at a different center, we say, well, wait a minute, why did we turn this down? And was this something that we should not have? And so we try to learn from our own experience of things. Mm-hmm. And we realized that some of the things like what traditionally maybe mattered, like the donor sequence number, we found it's been somewhat irrelevant. A good donor is a good donor, and we've been going to the hundreds in some sequences.
Wow.
Where the work absolutely wonderful. At the same time, with the recipients and us continue to push the boundaries, we have regular protocol meetings. Once a week, we talk about patients and selection and who is and who isn't an appropriate candidate. And we push each other to say, well, wait a minute. Even though traditionally this is what we've kind of thought about, there's increasing literature from X group or Y group or this database that says this might be okay. If you look at for example, the UNOS guidelines of standardization of recipients and donors, it's just guidelines. The data behind it isn't the greatest data. Mm-hmm. There's historical and retrospective reviews, but we really are in a field where it's so multifactorial that no one has really figured out all of the intricacies. Mm-hmm. And it's a kind of blend and a continuous balance between all of these risk factors that allow us to make appropriate decisions. And I think once you have that kind of vision, so to speak, to say, let's rethink everything on a routine basis, you become open to new ideas, open to new ways of thinking about things. And I don't want to say taking chances, but pushing the boundaries.
I'm always curious, particularly at major teaching institutions like Johns Hopkins, for people like yourself. You've spoken so much about your role being involved with collaboration and working with teams, working with partners, both within the hospital, outside the hospital. Obviously, in terms of teaching the next generation of surgeons, teaching them the technical skills and the medical skills are critical, but teaching them sort of these soft skills of working with others and asking others to challenge you and question yourself so that you can move the field forward, collaborate with partners outside. How do you approach that as part of the teaching when you're working with young doctors?
One of the hats that I wear at Hopkins is I'm the program director, so I'm responsible for the education of our fellows, who are really absolutely amazing group of individuals. They finished all of their general surgery and medical school and residency, and this is kind of their finishing school. And the hardest thing I find is changing the way someone thinks. We as surgeons are kind of creatures of habit. So in my operating room, here's how we do this part, here's how we do that part. Because if you start getting too lax, you'll start introducing other variables and maybe you don't have as good an outcome. But at the same time, you need to be open enough to say, well, wait a minute, if one of my partners does it this way and it works better in this situation, I want to be flexible enough to adapt that. And so for me, I always try to verbalize or vocalize things while they're happening to say, this is what has worked for me, and here's what I like. But I'm open to suggestions of what may work better, and ensuring that my mentees, so to speak, kind of hear that message. So that way, when they are graduating from this program, they don't have just the way I do a heart transplantation, but they see how Dr. Polanco does it, how Dr. Pasriza does it, and they kind of adapt each one of those things to their own. And that's one of the beauties of being in an academic center for me, is that there is no case where I see one of my partners operate that I don't take something away from. And I think if you have that attitude, you kind of continue to improve and refine the way you do things. And certainly there may be some things I do that are okay and maybe better, but certainly there's other things that people do that may work best in a different situation. And so we try to instill that on our trainees. Traditionally, heart surgery education is really, this is a disease process. Here's the pathophysiology. Here's what I want you to take back. Or here's a technical tenet of this operation, and here's the way you should approach it. More recently, though, our governing body of education, the ACGME, really has 6 different milestones or pillars of education. And medical knowledge and technical skills are only 2 of them. The rest are exactly what we're talking about, which is collaborating with others, the way you're exert yourself as a professional, communication, collaboration. And those are the softer sciences that we try to kind of really teach. So I try to have things like journal clubs once a month where we all get together and talk about science, as well as how we're going to talk about things. In addition, one of the great things about work at Hopkins is that we have this 360 evaluation where everybody that's part of the team gets a chance to evaluate you and tell you what they think about how your communication style may be, or how your professionalism, or how your technical skills. And I think in a subset or a organization that has trust and has common goals, that goes a long way. That goes a long way for self-betterment, and it has been absolutely transformative for educational program.
That's fantastic to hear. That's an incredible program that you've got there. Really excited to partner with you and work to help bring forward that future of transplantation. Before we go, I just wanted to check, is there any particular initiatives, events, or programs you'd like to highlight that are important to Johns Hopkins that are coming up?
There is a myriad of different clinical trials that we're part of. Our heart failure cardiologists are on the forefront of research as it relates to heart failure with preserved ejection fraction, sarcoidosis, and amyloidosis, and cardio obstetrics. That just about everything and anything you can think of is happening here. And if it's a very uncommon problem or a rare mutation, we absolutely love to work on those things here. We have a huge ARVC, arrhythmogenic right ventricular cardiomyopathy group, where we work really closely with our electrophysiologists to take care of these patients whose right heart's essentially just replaced with fat. We have a great research group. One of my partners, Dr. Chain Pasraja, is looking at solutions and potential optimization of temperature when we're taking these hearts. So the number of research initiatives is just a little bit too many at this, but it's absolutely delightful to be a part of such a forefront thinking group where if there is a problem that has arisen that we haven't been looking at, that we will be looking at.
Excellent. Well, thank you so much for your time today, Dr. Kilic. I can't thank you enough for both joining us today, but also, more importantly, for the work you do. Wonderful to hear that those 5 patients are all doing really well. We're really proud and humbled to be part of what you're doing there at Hopkins and the treatment you're helping to provide for more and more patients every year.
Well, thank you guys so much for the opportunity to chat a little bit today in your partnership and taking care of these patients. And I suspect with the way we're approaching things, we're going to be having an opportunity to take care of even more and more patients together. And I appreciate the ability to just have this conversation today.
Thank you.
Thank you so much.